Welcome to CeGaT, the best possible exome diagnostic.
Hello everybody, my name is Lea Schenke and I'm the member of the sales team here at CeGaT. I would like to welcome you to a very special seminar about Exome Xtra, and I'm happy to introduce to you two of my colleagues who will let you know why our Exome Xtra is better than an exome and smarter than a genome. In the first part of this event, Dr. Stefan Griesbach, my dear colleague, the head of sales, will give you a short overview of the development of our Exome Xtra and about the philosophy. And I'm sure with his technical knowledge, he can help you with this question as well. And in the second part, our colleague, Dr. Heinz Gabriel, will give a talk about the clinical application. Dr. Heinz Gabriel is a clinical geneticist, so he's more in the practical part here. And now I'm happy that Stefan will take over. So have a nice evening.
So welcome everybody, also from my side, and good evening, at least for Germany, good evening. I'm very happy that you are here today with us. And as Lea kindly introduced already, I will give you a overview about the thought process we had when developing our CeGaT Exome Xtra. I would like to start just with a few short reminder about what actually is the goal in our genetic diagnostics. So fundamentally, the idea is to identify the genetic cause of disease. On the left-hand side here, we have Saskia Biskup. Saskia, as being a medical geneticist, when she founded CeGaT 2009, had the idea to utilize the, at that stage, not used NGS technology in human genetic diagnostics. When we look about the process of genetic diagnostics, we have practically three parts. The first part is that we sequence all of the relevant targets for the patient to have the chance to identify the genetic cause of disease. On the second part, then in a bioinformatic approach, we look into the data analysis because the data amount generated by NGS technology is so huge that it is virtually impossible to do everything here by hand. Then in a subsequent, when this data has been enhanced by the bioinformatic analysis, we look into the medical interpretation part to make actually sense out of the variants that have been called. And in the below picture, you actually see our current building. We're right now sitting approximately here, and we're very happy to have you all here. When CeGaT has been developed, I already mentioned that CeGaT has been founded back in 2009, and already in 2010, we introduced at that stage the new diagnostic panels. Diagnostic panels are curated list of genes specialized for a certain phenotype of a patient, for example, epilepsy, and then we sequence all of these relevant genes. Since the first introduction of these panels back in 2010, I think the epilepsy panel in the version 1 had about 50 genes, which was huge at that time, but compared to modern technologies we have today at our hands, it's relatively small. This has been novel. We are focusing very highly on highest quality. Therefore, we have immediately started working on our quality handbook and acquired the ISO accreditation in early 2011. Subsequently, moving more and more internationally, we saw that CAP and CLIA accreditations are in high demand when going internationally. So we acquired them in 2016 and 17. And then maybe two more. In 2019, we introduced a variant of unknown significance re-evaluation program, and I will come to that also later in my talk. And in 2020, we introduced the CeGaT Exome Xtra, and today I will speak about the thought process in this development. And actually, we have just recently launched the second version of this panel, or this exome actually. This is us, at least this is us at the time of 2019 when we had our 10-year anniversary. And I mean, we had been lucky, such a crowded picture would today not be possible. So we're very lucky that this was possible at that stage, and we are very hopeful that we will come back to a status that this can also be done. We've seen here, these are, well, CeGaT in 2019, nearly 200 people, a highly qualified team looking to operate worldwide in the fields of diagnostics. We're focusing today on diagnostics, even so we also have a second arm, the Research Pharma Solutions, where we assist research groups in and pharmaceutical industry. We are always proud to use the latest technologies. Since I started at CeGaT in early 2013, I think we have like 5 generations of sequences done here. And so we're very proud now to operate 5 NovaSeq 6000 currently. And as I know our laboratory team, we probably will end up having another one very soon. Looking at the diagnostic portfolio we are offering, just for completeness sakes, we offer diagnostic panels as we introduced them in 2010. We have many different large gene collections here and to offer differential diagnostic options. One key factor is that we're always looking into a full analysis. So we're not only looking into SNVs, so the single nucleotide variants, we're looking into copy number variants. We always look on for the phenotype of the patient relevant mitochondrial DNA, and so on. On the very right-hand side, we offer tumor diagnostics for treatment decision support. Here, we look also in a large panel, tumor normal tissue comparative sequencing and identifying potential treatment strategies for the treating oncologist. Today, we will focus on the CeGaT Exome Xtra. As already mentioned in the introductory video, we think it's better than Exome, smarter than a genome, which is the best possible approach for patients with a complex, unspecific, and rare diseases. Before I go into the details of the CeGaT Exome Xtra, I would just, as a short reminder, go on Trio Exome Diagnostics. Trio Exome Diagnostics is, in our opinion, the superior approach compared to singleton exome diagnostics, simply because due to the comparative analysis of the index patient with the 2 genetic parents, we can filter much more in depth or detail the potential highly likely pathogenic variants, or the most striking ones, for example, de novo variants. The exome is the part of the genome that encodes for protein. This is roughly 1 to 1.5% of the whole genetic code. And we know that at least current state of knowledge is that we have 89% of all genetic diseases are caused by changes within these exonic regions. Every human has thousands of genetic variants, which are benign. And obviously, it's our job here to filter down the variant that is disease-causing in the patient. To give you an example about the potential this diagnostic has, we have here a sample case of a girl of 6 months of age. She had a bone marrow developmental defect, and the brother died at the age of 7 months with similar symptoms. So it really looked like genetics. Nevertheless, the treating physicians here in the University of Tübingen didn't really know what to do. So they approached us to do a trio exome, while at the very same moment scheduling for bone marrow transplantation, which is quite a harsh procedure for a baby at that age. And I was told that survival chances are roughly at 50%. When we looked on this case, we found obviously something. So first of all, this actually is the baby Lila at that stage. So she was really not doing well. When we looked into the results, we identified a variant in the TCN2 gene, which encodes for vitamin B12 carrier protein. The physicians had no chance to see that. Blood levels were normal, and so they had no chance to see that there is potentially something wrong with the vitamin B12 system. Here, the consequence was that the baby got high doses of vitamin B12, which then compensates for the reduced translocation of the vitamin from the blood to the bone marrow, and the bone marrow subsequently developed normally. And this is the baby Lila, not as a baby anymore, but about 2 years later, and she's absolutely developing normally. Obviously, this drastic effects is a rare case. Nevertheless, is one of the cases that tells everybody here at CeGaT why we are doing what we are doing. These are the cases where we want to help the patients. So when we now looked at the process and said, okay, Exome Diagnostics, we know 99% of the variants of the disease-causing variants are within the exonic region. Nevertheless, how can we do better? What can we do? And then we looked at this process in detail. And as I mentioned before, we have these 3 steps. We sequence, we do bioinformatic, we do medical interpretation. We can only do a medical interpretation on data that has been bioinformatically processed, and we can only process positions that have been sequenced before. So let's start making the most data on sequencing. Before we looked into how can we make the exome better, we thought we'd have to identify what actually is, with today's technology, the theoretical limits of sequencing we can do. So what is the case if we say costs doesn't matter, let's do whatever we can on sequencing? So we used a whole genome sequencing on a PCR-free approach with a paired end 100 base per sequencing and over 500 gigabases of raw data, which obviously is a huge amount. And I think if somebody would have to pay that, that would be nothing that you can afford on a routine basis. So, and don't worry about this quite a complex table. I will walk you through that. So what have we resulted here? First of all, the first line, the raw data. The raw data means that when we take everything, how we get it from the sequencer, and we map it to the genome, we get an average coverage of 133. And CDS means all part of the codings, all coding sequences. We covered them with 99.77%, so virtually everything. And when we look for the disease-causing intronic mutations and intergenic mutations, we as well nearly perfectly covered that. Obviously, that was expected. But these data cannot be used at that stage for clinical genetic diagnostics. We have to apply a lot of filter criteria to solve or to remove the ones that don't have sufficient quality. So first of all, we remove everything that is not uniquely mapped. Then we remove everything that is a PCR duplicate. Then we only use high quality reads. And then at the end of the day, when you have the overlapping sequences from sequencing, we only take this once when you have one fragment sequence from both ends. So when we did all of that, we ended up with a coverage of 111. When we look on the coding parts, we got 98% only covered. As you see, the majority got lost from the raw data point to the uniquely mapped. These are all the ones where we have pseudogenes, for example, that cannot be precisely assigned to the one or the other sequence, and therefore, when we're doing the diagnostics, we would not be able to distinguish between the variant being located in the pseudogene or being located in the real gene. When we look for the disease-causing intronic variants, we haven't lost that much. Again, this was also expected, as the majority of these variants have also been identified using the very same technology. Okay, now where have we been when we looked into this in 2019? And one point here is that this is already a CeGaT optimized TwistCore Plus enrichment kit, which we used at that stage, and not a standard of the shelf product. We had a whole exome sequencing, paired end, 15 gigabases of raw data. And again, the very same table. Interestingly, when you look at this, when you look on the coding parts, you are ending up nearly to the same level as you ended up with the whole genome sequencing. When you look on the non-overlapping, uniquely mapped, and so on the clinical usable coverage, again, it's very close to the whole genome. So this enrichment kit already works very well for the coding parts. When we look for the intronic disease-causing variants, here, obviously, there's kind of a big gap. So we lost about 5 to 6% of the variants that could be identified in a whole genome approach. Again, this was expected, as this kit does not enrich for any deep intronic intergenic variants. And so we're covering here all disease-causing non-coding mutations that are close by an exonic region. Okay, real life is a little bit different. Costs do matter. So how is whole genome sequencing actually performed in a diagnostic setting if it's done? So we have here now a whole genome sequencing, again, PCR-free approach, paired and 100 base pair sequencing, and 95 gigabases of raw data, which corresponds roughly to a 30x average genome. And I would spare you now the details of this whole table, and we'll just move to the very end. So what we end up here is, when we look at 30x diagnostic threshold, 30x coverage, meaning that one position is covered 30 times. And my apologies, I missed that. All the variance and all the data I gave you before was based on the 30x threshold, as we strongly believe that 30x is the diagnostic threshold to be used. Why do we do that? Because when we have a position covered 30x, identifying a heterozygous variant, we do stochastically with a chance of 99.999%. So we nearly don't lose anything. While when you go to 99%, when you go to 20x, you only have a chance of 99% to identify a heterozygous variant. This is plain simple stochastics, as we need 5 reads covering the variant of interest. And when you do the math, you end up with these values. So when we look at 30x, obviously, it's not really fair to compare 30x on a 30x average genome. Nevertheless, we end up with only 27% of the coding and the intronic variants being covered sufficiently. Okay, let's say we go down to 20, because if we have a 30x average genome, that should be kind of good. Still, over 10% of the coding regions and the intronic regions are not covered sufficiently. So actually, we're losing quite substantially on our diagnostic yield, utilizing a 95 gigabases raw data genome. This is why we conclude, okay, this is a very useful approach when we're doing research, but it's not the suitable approach doing a diagnostic setup. Okay, we have identified where we can get when we use unlimited resources. We have identified where we are. So now we are on the way to design an Exome Kit that covers all variants known to be disease-causing, and on the very same moment enable us to be cost efficient. So we started off adding what we did before. So we had a twist course exome, we had a RefSec spike in to cover further relevant genes and transcript. We added the complete mitochondrial genome. So this was a good start, but nevertheless, we should do a lot more. So first, what we added is we looked at our diagnostic panels. And when we had our diagnostic panels, these are the ones where we did for years and years the primary research on the publications, identifying all targets, maybe intronic targets, it might be some other transcripts that are not covered. So we looked for all of these manually curated coding and non-coding regions from our diagnostic panels, which covers hundreds of diseases, and added all of these targets to the system. We then said, okay, we're not the only one doing research, so obviously we have to look for public databases, and we also added all pathogenic and likely pathogenic variants of non-coding variants described in the HGMD and ClinVar. We then said we have another database which comes together from CCDS, from GeneCode, from a sample, from RefSec. So everything where we could lay our hands on, we put it into this database, and we added then this one on top. And this is where we are today. When we use our CeGaT Exome Xtra, we sequence again 15 gigabases of raw data in a paired and 100 base pair approach. And we end up here with an average coverage of 111, with 97.5% of the coding parts covered, so nearly the same as we did for the whole genome with 500 gigabases. We have over 99% of the disease-causing intronic variants are covered, so we are very, very, very close to a 500 gigabase genome. So when we look on the design, to sum that up, we have all diagnostic relevant targets similarly covered to a 33 times more sequencing data demanding genome. We have much lower underrepresented rates than a whole genome sequencing, how it can be used today for diagnostics. And actually one very important point is that we actually have a chance to identify mosaicisms, which is virtually impossible to detect on 30x whole genome sequencing. And this is why we conclude that our enrichment is much better than normally done for an exome, and it's much smarter than a genome. Okay, so we optimized this first part of the process, how about the second part? What can be done in bioinformatics? Again, idea is we generated now this fundament of data. All these interesting variants are covered. How can we ensure that we don't lose anything on the way in bioinformatics and enable our diagnostic team to do their job best? So first of all, obviously, de novo variants are variants that are present in the index, but not present in either of the parents. And then we have the homozygous variants, we have compound heterozygous variants. So compound heterozygous variants are when you have one variant in one allele from the parent inherited from one side and another variant, and both coming from the other side, both coming together and ending up in a causative setting. This actually, and the X-linked variant, so this is a regular tree of filtering. We account for loss of heterozygosity and parental mosaicisms. And actually we do all of that for single nucleotide variants, for copy number variants, and also for single nucleoside variants and copy number variants combinations. So you actually account for the one situations where we introduce an artificial stop codon on the one allele and have a 3-exon deletion on the other allele. This is fine, but we want to do more. So what can we do actually more here? The one is that what we found in discussions with our treating physicians, that we have a lot of cases where the parents share a variant but do not show symptoms or only show mild symptoms. So this is why we added a system where we account for variants in genes with reduced penetrance, viral expressivity, and even considering imprinting effects. Then we have quite often the setting, well, not quite often, but we have sometimes the setting that a trio is simply not possible. So we have other type of combinations, and we're offering optimized pipelines for various non-trio constellations as well. To give you one example, what this means in a clinical praxis, and I don't want to jump forward to Heinz's talk, but to give you one here, is we had a case with a suspected Beckwith-Wiedemann syndrome, and you can see all the indication here. There has been nothing done before. The pedigree didn't show any other family member affected. When we looked into this, what we saw is that we have a variant, a likely pathogenic variant, in the CDKN1C gene. And you actually see how that looks one here. So we have the index in the most upper panel. Then we have the mother here, the father, and our reference sequences. When we look here, you actually see this is the variant of interest. And actually, the mother shares exactly the same. So why is this one interesting? Because here in CDKN1C, a parental imprinting is happening, and that means that only the maternal allele is expressed. The mother has very likely inherited the variant from her father, so she is not being affected, being completely asymptomatic, and simply because of the fact that the pathogenic variant or allele is not expressed in her. And this is one of the variants that would have been immediately sorted out by a regular trio exome bioinformatics filtering. It's a single heterozygous variant inherited from one of the parents. Okay, with this one, I want to move on to the medical interpretation. So first of all, how do we actually evaluate variants here at CeGaT? We're strong believers in the combination of human knowledge and bioinformatic analysis. The bioinformatics helps our scientists to do the best job, but it's an assisting tool, and the fundamental knowledge still lays within the scientific experts here. We have an in-house developed software that helps these scientists to evaluate the data. Still, a total of 4 scientific experts is working on each case. Our interdisciplinary team obviously uses the most recent literature for data interpretation, and our final reports are revised by our medical team and geneticists and to maximize the clinical medical usability. The primary goal of the genetic diagnostics is to identify the causative variant in the patient. So we need to optimize here. So we have obtained all this data, and we want to use the best clinical usable data that we can have and optimize here. So we allow, obviously, for ACMG genes, so we can generate a second report if requested on the ACMG gene list to allow pathogenic variants outside the primary phenotype of the patients to maximize usability here. And actually, we are offering a pharmacogenetic option where we analyze known variants in 20 genes involved in drug metabolism, handing over again a second report where clear recommendations for certain drugs are presented, where it's, for example, adding, adjusting the dosage, or maybe utilizing a different drug for a certain treatment. One other point is what we want to do is we want to keep track on the open cases. So we, as I already mentioned in one of the first slides, we introduced a WUS, variant of unknown significance re-evaluation program, as a standard for all our NGS-based diagnostics in 2019. We monitor all unsolved cases for the reported WUS we had in the report. And if the classification has been changed in a database like HGMD, they actually manually re-evaluate this variant of unknown significance. We do this because when we did an initial screening on that, we saw that actually in the majority of cases, when we have this WUS re-evaluation because of a classification change in HGMD, this change of classification is not relevant for the phenotype of the patient, but for different phenotypes. And if we then come to the conclusion that this variant is of relevance for the particular patient, we will go to the treating physician, inform and ask if a revised medical report is wished at that stage. And obviously, this is a program we do free of charge. How does this end up in clinical practice? This is a very recent one from our last round of re-evaluation. This was a boy, 11 months of age, when we did the initial report. It had benign infantile epilepsy, and we reported a variant of unknown significance in the SCN8A gene. You see that particular variant mentioned here. There was a WUS re-evaluation triggered by the HGMD update in January this year based on a publication of end of last year, and the variant can now be clearly identified as likely pathogenic, and a new report has been issued and sent off to the physician in order to have now solved this case for this child. So to wrap up once again, our CeGaT Exome Xtra, we have optimized all 3 steps of the process in the clinical genetics. We optimized the sequence to gain everything that can be used in clinical diagnostics. We optimized the bioinformatics not to lose anything in the filtering process. And to give you a rough idea, when our team does an exome analysis, there is a solid 3-digit number of variants that are manually evaluated on average. And when we do the medical interpretation, we ensure by the knowledge of our team and the routine they have that we will receive for you the best possible report to use for your patients. And with this, I'm through with my part of the talk. I don't know if there are any questions right now, Leah?
No. Now I think Heinz is ready. So he will give a second part about the clinical application.
So hello everybody, a warm welcome from my side. First I have to start the presentation. So okay, thank you very much. Now I think again a warm welcome to my presentation. So I'm not part of the sales team, so the presentation I give you today are really from our diagnostic workup, and I will show you within the next 30 minutes around how we use the CeGaT Exome Xtra to perform diagnostics here in-house and how it performs really on everyday work. So a good idea, or in an ideal world, you would have one single technique to cover as many possible applications as you can imagine. And that's what we like to obtain with the CeGaT Exome Xtra. And I will address 2 or 3 of these points. So of course you can do single gene testing with an exome. However, it depends on the size of the gene, whether this makes sense or whether you still perform Sanger sequencing. Stefan gave you a good introduction of 2 exome testing, and I will show you practical samples where we use this approach. And there was already a question about microarrays. I will give you an example about CMV detection with this exome. I will not address panel testing, and we can also use the trio exome sequencing to detect UPDs, which I will not address today. And depends on time, I will show you also an example how we detect a mitochondrial mutation in a low heteroplasmic mosaic. The first example I will show you is from a prenatal test. So we used our exome since I think 2 years, really on everyday basis to do prenatal testing. We have performed more than 700 samples. And as you can imagine, if you do prenatal testing, all your workflow has to be reliable, fast, and stable. And we now can do, in most cases, we get the result within 2 weeks. So it's about around the same time as if you do traditional karyotyping. And moreover, we can now do it when we use a low input protocol, really on native samples. So we can use amniotic fluid as well as chorionic tissue, and it works quite well. So in this case, it was in a 23-week of gestation, and we have ultrasonic finding, which was an intrauterine growth restriction, shortening of the long bones, micrognathia, and also heart defect. And we performed trio exome sequencing with the CeGaT Exome Xtra. And now I try to get you through these slides. So this is our in-house software, Stefan already mentioned before. And what is displayed here? At the top level, you see a chromosome. In this case, it is a chromosome 4. And as we perform the trio exome sequencing, you have 3 lines of data here. In the upper part, this is a fetal DNA sample, and you have the mother and the father down here. And what you see here on the blue dots, these is the average coverage of the sample compared with the reference data set. And if you have a drop of coverage, you will have a deletion. While when you have a higher amount of coverage, it will be duplication. In this case, you see here the yellow line. So the signals here are dropped down, so which is indicative for a deletion. And on the right side, it is enlarged. And as you can see here, it is terminal of the short arm of chromosome 4. And what you can also see here is that the mother and the father shows not this aberration. So it's a terminal deletion, and which is quite known. It's a Wolff-Hirschhorn syndrome. And if you compare the phenotype, which is well known for this syndrome, so it fits quite well. And it's a de novo event, so of course you have to test for balanced translocation in the parents. However, so we could do a diagnosis, and this within 2 weeks without any FISH approach or with any other microarrays on top. So CNV detection works quite well in most cases. Always depends a little bit on the quality of DNA. And in fact, during prenatal testing, often we get cultured cells, so then the quality, in fact, is indeed a little bit dropping. However, if you use good native samples, so you get these high quality data, and the CNV detection down to single exon resolution is possible in most cases. So, and the next example I will show you is how the new exome approach can really push up your diagnostic outcome. So this was a case which was diagnosed in 2016. So we had healthy parents from Kosovo. They were first-grade cousins, and they have 2 affected childs, a boy and a girl. And as you can see from the clinical phenotype, on the left side, you see the phenotype of the boy, on the right side of the girl. And it has to be clear that both childs are affected by the same disease. So it has to be some genetic background. So we performed a quadro exome analysis, so where we include both parents and both affected childs in this analysis. At that time, we used the Agilent version 6 exome enrichment system. And so we were rather optimistic at that time to find the cause, but as a little bit disappointing, we got a negative testing result. And as we always recommend in diagnostic, which is a standard recommendation, if you have a negative testing result, we say, okay, contact us 2 years later or a couple of years later and ask whether we have a new diagnostic approaches or techniques or whatever to solve the case. And this was also happened 4 years later. So they asked for a new diagnostic test. And this time we used the CeGaT Exome Xtra approach, and we performed not a quadriexome analysis at that point. So we used trio exome sequencing with the little girl. And what you can see here, I don't worry, I will guide you through the slide. This was the result of the CeGaT Exome Xtra, and we found a variant, and at the top level there's the affected girl, and here's the mother, and here's the father, and this is a reference data set, and there was something found here, so it's a homozygous small deletion, which was found in a heterozygous state in the mother and also in the father as well. And down here, there's a gene. You have one gene, and the transcriptional start will be here. So this alteration is located in the promoter region of a gene, and so it's not part of the coding region. And so then we checked, why was it not possible to detect this variant? I will show you that this is a causative variant 2 slides later. And we looked at the Agilent version 6, which we did at that time. So it's not the version 6 data set of the parent. So this is another Agilent version 6 data set. But this is a position. And as you can see, with a coverage of 9, it is not possible to do diagnostic. So it was really not. So at this low level coverage, all the data will be filtered out by the bioinformatic pipeline. So it was not possible to really detect this variant. And with the CeGaT Exome Xtra, we will have a good coverage of more than 200 in this case. And so it was really possible to detect this causative variant. And however, still the question, is this really the cause of the phenotype of these both affected childs? And it is. If you go to the oming phenotype, you can see, I will not go in details through all these phenotypical symptoms. However, it fits quite good. And and then another fancy thing is that this variant was also described in 2017 as a founder mutation in a Roma population. And in the Kosovo, there's a quite large Roma population found. So we considered this case as solved. Now I give you another example, and this is a sample which we solved 2 weeks ago. So it is a really recent case. And here we already use the CeGaT Exome Xtra 2 version. And in this case, we had no parents, but we from the consent form, we know that they had parents from islands which were not related. However, they had 2 boys which were affected by the same disease. And this is a quite peculiar phenotype because you have mainly immune deficiency phenotype and a skeletal dysplasia phenotype, which is really a strange combination. So we did not perform trio exome sequencing. We do exome sequencing for both affected boys and do a special analysis, we call it a shared variance. So it has to be, it's clear that both boys had the same genetic variation which cause the phenotype. So we can compare the exomic data of these two boys to really filter out the hopefully causative variant. And this was done, and as you can see here in the upper panel, this is a boy 1 and this is a boy 2, and we found 2 variants. And down here you see the name of the gene, which is the RNU4-ATAC gene, which is an RNA gene and which is located within the intronic region of another gene. And so it's not part of the really coding region of the genome. And both boys share the same variant. And so as both variants are really close to each other, it is also possible to tell whether these variants are located on the same allele. And before I show you this data, this is the twist exome, standard twist exome, and we look for this region. In this case, I just chose, we have almost no coverage, so it's a coverage of 1, which is not possible to detect any variants in this, with this not really existing coverage. You can do phasing, or what it means. So the forward strand is colored in red, while the reverse strand is colored in blue. And if you enlarge it a little bit, you can see that one variant is always found on one strand. So from this phasing, you can tell that both variants are really located on different alleles. So you don't, in this case, you don't have to do segregation analysis of the parents to identify whether these variants are biallelic or located on the same allele. And this is known. However, it cannot be detected by standard exome sequencing, but nevertheless, it is known. And what we found, okay, in both affected boys, it's present, and we have an autosomal recessive trait, and the one variant was already described as pathogenic, and there's also in the literature the second one described, so we gave, according to the ACMG guidelines, a likely pathogenic classification. And there are, if you go to the OMIN database, there are 3 phenotypes linked, and there are 3 phenotypes associated with this gene. And from the literature, both variants are associated with the Roifman syndrome. And what is this gene doing? As I told you, it's an RNA gene, so it's not protein coding. And it's together with another RNA gene, the U6-ATAC gene. It is involved in splicing of a set of around 17 different genes. And for these function, most important is the 5' stem loop structure, and one variant is located in this structure and the other is near the structure. And if you go to the OMIM phenotype of the Roifman syndrome, as you can see, there is a skeletal phenotype, and there is also immune deficiency phenotype. As you see, it's a wide complex phenotype, so it's not so that all the symptoms have to be present in every patient. However, with this pathogenic and likely pathogenic classification, and so we were able to solve this case, and as hopefully could demonstrate this was not possible with the standard exome enrichment procedure. So now the case is solved, and if the parents like to have another child, so they will can be informed about recurrence risk. So it's really possible to make the diagnosis. So the last examples I will show you is how we use the CeGaT Exome Xtra on mitochondrial DNA. So this case, we have healthy parents from Germany, and they had one affected young girl and shows severe global retardation, hypotonia, and blindness. So this is a really good example for trio exome sequencing. And what you found here is a mitochondrial DNA where we have a high coverage of about 100 55, and we have in a low heteroplasmic mosaic a variant which is not found in the mother or in the father. So I don't go into details about mitochondrial inheritance. It's only transmitted from the mother. And okay, is this the cause for the phenotype? We are not sure. So it's on the mitochondrial DNA. However, it's still a class 3 variant of WUS. So it could be causative for a mitochondrial complex 1 deficiency, which can explain the phenotype. It always depends on the heteroplasmic state in other tissues, which we have not tested. Just the proof of principle which show you how we can use this approach to really detect low mosaicism in mitochondrial DNA. So I cannot tell you that this case is solved. So here we have to go back to re-evaluation of the variant maybe in 1 or 2 years, and maybe then we know whether this is positive or not. So these were some examples from our everyday work, and you already have seen this picture from our 10 years anniversary. So we are a rather young company, as Stefan already told you. And sure, this time, even with all these masks, it's not possible to come together in this way. And so hopefully for a better time where we can spend some time together without any mask anymore. So thank you for your attention, and I'm happy to answer your question.
In case there are questions arising later on, you can always contact us. Thank you, Stefan. Thank you, Heinz, for your nice talk and for your detailed information on the Exome Xtra. And thank you, the audience, for your attention and your participation and your time you took. Have a good evening and take care. So, bye-bye.
CeGaT Exome Xtra. Better than exome, smarter than genome.